All right, so we're going to keep Amy White up here for our panel. And we're going to be now going into an active session where we'll go through several cases that are not actually just newborn screen, but Krabbe disease presenting at different ages. And we're going to bring up our panelists to go through these cases with us. So we're keeping Amy White on one of these two sides of our little table here. I'm going to call up Dr. Joanne Kurtzberg, who is professor of transplant medicine at Duke University and director of the Marcus Center for Cellular Cures. So thanks for coming up. Dr. Dieter Matern, we've already heard from, is going to come up as well. Dr. Joe Orsini, deputy director of the New York State Newborn Screen Program. And Dr. Margie Ream, associate professor of pediatrics at Nationwide Children's Hospital and the Ohio State University. I'll be staying up as well. Okay, great. I'm going to steal a microphone too for our audience here. So it is. Okay, great. So here we're going to go through some discussion. It says newborn screen case, but like I said, not all of these are newborn screen. We have 3 cases that we're going to go through with a possibility of a 4th if we have time. So let's just get started. This is a patient not identified through newborn screen. This is a 6-year-old who presented with several months of tremor, a mild ataxic gait, and toe walking. This patient was very functional at the time of the initial presentation and cognitively neurotypical. The physical exam showed some mild lower extremity spasticity in the proximal legs. So you could see that if these symptoms are due to Krabbe, that we have some mild symptomatic progression already. Okay, so we have some stats here, as I put it. So we have a genotype, which we'll get Amy White to tell us a little bit more about, maybe, if you could see them.
I think it was the father had the pathogenic variant and mother had the likely path. And there were also pseudodeficiency alleles. So yes, I see that there too. They were each heterozygous for the I562T and D248N. And thank you, not to spoil it for later, but there's a sibling we'll talk about too. They both had the same genotype, which I think is important to know. And the initial testing was done overseas in Europe, but we were able to get the pseudodeficiency alleles when we asked, which I think is an important point to mention. Not all labs will report them. You may have to ask for them.
Great. We'll come back to you in a second, Dr. Kurtzberg. I just want to point out that the cycosine here is on red blood cells. So again, really important to distinguish between that and dry blood spot. Here we're seeing from the Mayo lab, normal level is under 5, and the level for infantile Krabbe and red blood cells is usually at or above 50, right? You can see the units there. And then our GAL-C from the Wenger lab, you can see as well. So I guess my first question, I'll just bring to the audience just to get a sense of what we think about this. If we think there's, a good chance or possibility these symptoms are from Krabbe, and would people move forward with further evaluation? If so, how urgent might that be? Any thoughts on this one? Some great clinicians here. Yeah, over here. Hold on one second.
May Baker from Wisconsin, newborn screen laboratory director. I want to ask the SOTU division allele here, is that to become a mode? Because you already have two pathogenic variants. So in that situation, did you think the SOTU division allele just noise here?
That's a great question. So, sorry, trying to use my counselor voice. That's a great question. What we found is that in a number of cases, when we learn about that, especially the I562T allele being part of a haplotype with a pathogenic variant, it reduces the Gaussian enzyme activity even more. And so sometimes we're seeing earlier ages of onset in those patients that have I562T than without. So when I mentioned earlier the New York case of the Y319C homozygous baby, it's the only one that's been identified that's also homozygous for I562T. And there are a number of papers that show in cell studies and animal models that it does significantly reduce the Gaussian enzyme activity. And so it seems like there's a compounding effect. Now, in this case, did you want to comment on it for the presentation?
I was going to, yep, well.
Mhm.
I think what's important in this case in relation to what you're just saying is also, as we alluded to, she has an older brother who has the same genetics, is also has a diagnosis of Krabbe disease, but was asymptomatic, and he's 3 years older. So I don't know. I mean, one family doesn't make a story, but in this family, it didn't affect the age of onset the way you might have predicted. And actually her enzyme level is a little higher than his, for what it's worth. I don't think we know, but yeah. But the other interesting thing about this case is dad's from Denmark. His parents are neurologists. They noticed that the little girl had a tremor when, they didn't see them every day. So when they saw them for a visit over Christmas, they noticed that the little girl had symptoms, and they were the ones who brought it to the family's attention. Took another 6 to 9 months for a diagnosis to be made. So it wasn't rapid, but it was the grandparents who were both, I think had more of an eye and hadn't seen her for a while, who noticed the early symptoms. And I think you told me that one of these mutations was from Europe, was Danish, but or Finnish, right? And then, but the father's from Denmark, and the mother has the mutation. She's not from that area of the world.
We have Dr. Levy over there with a question or comment.
Yeah, I think this case points out the holes in our knowledge about Krabbe disease. You would expect with such low enzyme activity that if the kid was going to be symptomatic, the cytosine would be elevated. I think what I would do if I was seeing this kid is I would then go on to other stuff. I would want to know what the MRI showed. Is there demyelination? If there's no demyelination, I don't know what I'm doing. Is the CSF protein elevated? Are there other signs of Krabbe disease in these kids? And then if that was all negative, then I would probably do exome or genome sequencing to see if there was some other reason for their neurologic symptoms.
Yeah, great point. So thinking about what is the probability, I guess that's a big question, right? What is the probability that these clinical symptoms are related to the GAL-C molecular genetic testing? That's a question. The cytosine in red blood cells is elevated at 10 because the normal is under 5, right? Is 5 itself is elevated, or is that normal? Doesn't matter. Okay. 4.99. Okay, so above 4.99 is elevated. And a question on there that, just kind of bringing up, kind of based on what Dr. Levy was saying about the cytosine and the elevation is, what is the usefulness of cytosine in the possibility of juvenile Krabbe disease? What is the usefulness if you send a dry blood spot at that age versus sending it in RBCs, and how much do we know about these values in these more rare patient populations? I don't know if you want to comment on that, Dr. Matern.
So how did we get to the genotype? Was that through exome or something?
Yeah, the grandparents arranged for it to be done in Denmark,
Right.
and it was
So,
whole exome sequencing.
so that was done already. And that revealed the GALC genotype, which was then further expanded on. And then the cyclozine was tested and GALC activity was determined. So, and cyclozine is elevated. I think if we, yeah, I know it's 10. I'm trying to show you in the various forms of Krabbe disease.
Do you want to
Um,
stand up so you can see the?
Yeah, I don't see anything.
Yep.
So what you see here, and it's zoomed into, so these are infantile Krabbe disease cases, 65 of them, and this is dried blood spots. So you can see they're very abnormal. Here are the controls. This is late infantile Krabbe disease, 45 cases, and these are not all newborn screening. These are overall, and you can see there's overlap with normal. And then you have juvenile Krabbe disease, and actually the patient has, oh wait, sorry. This is, you see there's overlap with normal quite significantly, and then there is the adult onsets that have normal cyclozine in blood spots. So sensitivity in dried blood spots is not very good, so you really should use it only for newborn screening because that's the specimen you have. Now, if you look in red blood cells, it looks very similar. Infantile Krabbe disease is very abnormal, usually greater than 50. Late infantile Krabbe disease is also separated from normal, so that's good. And also the juveniles, we have only 8. They're separated from normal, but it gets tight. And 10 was what this patient had, and it's right the median of all these 8 cases of juvenile Krabbe disease. And then there's adult onset, and there's overlap again. So the milder the Krabbe disease form is, the harder it gets even for cyclozine to identify them.
And I just want to point out, this is at diagnosis, not a newborn blood spot,
Right.
right? So there's 2 questions. One is cyclozine helpful at the time of diagnosis for these later onset forms? And it looks like yes. But the second question, I don't think we know the answer to, which is cyclozine in the newborn blood spot predictive? I don't think we know yet of these late onset juvenile or adult form.
Yeah, it seems like cyclozine is likely helpful, but with the caveat that with juvenile or adult onset, it's tighter with the normal range, number 1, and number 2, as Dr. Matern pointed out, these case numbers are small. So it's a little bit harder to be sure, but it's pretty clear from what you went through that if we're going to do cyclozine in these types of potential patients, that it should be in red blood cells and not in dried blood spot.
So, but again, I think if cyclozine is elevated, that is not normal. So you might miss cases because there's overlap with normal, but if cyclozine is elevated, until proven otherwise, that's Krabbe disease to me. And I don't care about the genotype.
Hello. Yes, so my follow-up question of that, as we were talking about all these cases, I went back to my own cases. And just to give an example, I have a kiddo whose dry blood spot was 1.8 nanomolar and follow-up blood testing was 8. So the question here becomes is, what's the utility of repeating or following up a cyclozine level in blood in kiddos who are below the cut line or cutoff of 2?
So I had a little trouble hearing, but you're asking what's the
What's the utility
predictability
of
of
repeating cyclozine
Repeating
in RBCs?
as a
in
sign of,
RBCs.
as a sign of disease
Yeah.
activity?
Yeah, so we
right?
have in this case, for instance, in my case, we have 2 potentially one pathogenic mutation and 1 possibly pathogenic mutation. We have a dry blood spot cyclozine of 1.8 nanomolar, and a follow-up in hemoglobin testing with 8. So, you know, where is the concern here? Is there a reasonable thing to think maybe this kiddo is now more in the potential earlier onset Krabbe or late onset Krabbe versus, you know, or less than 2, then we may not worry about that as much. I guess I wouldn't. I think I will worry. And so anyway, so I just want to, we in our genetics colleagues do repeat these cycosines. And so what's the utility of repeating it? Is there, I do see fluctuations in the cycosine 2 or 3 points above or below. So what do we do with that information?
Yeah, I go then. You go. So my only experience with that is with the kids we call the New York twins that Joe and his team picked up as newborns with very low enzyme and intermediate cycosine, and we followed till they were 15 months old when they developed MRI changes, et cetera, and they were transplanted. But their cycosines stayed within a range. They did not shoot up at the time that the MRI changed in those kids. But having said that, I don't think we really know. And I will also say, and Dieter can comment, in our post-transplant kids, we've started to follow cycosine, and it doesn't normalize in most of them, comes way down, but it stays in that sort of mostly intermediate range. I think, and yeah.
I was just looking for clarification. You said 8 for cycosine and 1.8. Are those in? Okay. And then 8. Okay. Yeah, I kind of consider those to be both in that same range. There's kind of like a factor of 5 roughly when you look at the, the normal range and where infantile begins. So infantile 50 in red cell and 10 in dry blood spots. And just to clarify, the reason we went to red cells was to eliminate the variability of the matrix of a dry blood spot, which can have variable red cell, white cells, and it's much less unknown what those values are. So yeah, following with the red cells, that's why we recommend that. I don't know if there are any other comments.
Yeah, so again, after newborn screening, I would switch to red blood cells. And then I would stick with it. I mean, when I heard Joe for the first time at the Hunter's Hope meeting, whatever, 10 plus years ago, talk about cycosine, I thought, okay, well, there we have it, the Holy Grail. We'll measure it in newborn screening, and if it's elevated, it's Krabbe disease, and then we measure it over time, and then you realize, okay, now it's going up, so now we do the transplant, and none of that turned, well, some of it turned true, but not the follow-up. So you can follow cycosine. I think it is reassuring after the transplant that it goes down, although it doesn't normalize, just like the enzyme activity goes up. So this is kind of what you want to see from my laboratory perspective. I'm always like, well, how's a patient doing? Because you don't treat the laboratory, you treat the patient. But I would stick with one sample. Now, further confusing is that there are, especially in Europe, and then in the US for some time, there was one lab that measured cycosine in serum. I'm still confused about it because they say, oh, it works great. And when we tried it, we clearly have much lower sensitivity. And remember, we're talking about nanomoles. We're not talking about even millimoles. In the red blood cells, it's picomoles. So you really have to have very sensitive equipment to even be accurate at the low levels, which is still a struggle. And so we're trying to, okay, now we go to the next level of mass spec, so hoping that we can have better differentiation at the low end. So it's a moving target. New technology comes up, and we're still looking for better markers too. So we're not done yet. I think there was a question in the back.
One quick sec. I think that's Katie back there, but it's hard for me to tell. So we just had a couple questions on the chat. 2 of the questions were about further testing, which we will get to, MRI, nerve conductions, that kind of stuff. But then one of the questions was asking about the genotype. Has trio testing been done? So they want to know the phase.
I think the beginning of the
Oh, it says phase on. Right?
yeah, it has
Yeah,
phase
yeah.
on there for the 2 variants of concern, not for the pseudodeficiency alleles. We did exchange emails with the lab in Denmark, and they did share that, but now I'm I think one of these is more likely to have it in the haplotype than the other, but we did have phasing information to know that they were in trans for these kids.
Okay, awesome. All right, Katie.
My question was along those lines. I would think the most interesting part is the brother. And so the brother's 3 years older, and you said he has the same 2 genes, but not the, I'm going to use the wrong word, the pseudo.
No, he has everything.
His genotype.
Yes,
is
everything.
right.
Those as well.
Yeah. And we will
And he
present the
is-
brother.
And so I guess I don't know the experience well enough. How much of a correlation do you see in time of onset in families with the same exact mutations? Because I mean, to me, the brother's the most obvious piece of data, but I don't know, maybe there's much more wide range in onset than I'm aware of.
Yeah, that's a good question. Just following our biochem lab data, we have some discordant SIBs, but it's usually discordant in age of onset and that they're both affected. So I think it's different in this case. And again, I know you're going to present on the brother, but he has he has autism, but otherwise, from a Krabbe perspective, is asymptomatic.
Yes, we do have a slide on brother, but it sounds like there can be some discordant age of onset, but usually they're both affected.
And I mean, not to speak for him, but David Wenger has, I know, a handful of cases, particularly later onset cases in families where there can, I don't remember all the time intervals, but they were years different between the siblings who ultimately presented.
All right, so we had some discussion there of the psychosine, which was really good. We have a suggestion to get an MRI scan to understand if there's demyelinating changes. We didn't quite touch on how urgent that should be. We know if this is juvenile Krabbe disease, that progresses more slowly than infantile Krabbe. On the other hand, there's symptoms, right? So I guess I'm wondering from Dr. Ream, how urgent, if you were seeing this patient, how urgent would you consider testing?
So even knowing about the brother, I would approach this patient as an individual since there's some variability within families. I'd be very curious to know the symptom progression. And if the family hadn't really noticed it, that's going to be difficult to ascertain when symptoms actually started. Generally speaking, somebody like this is going to get diagnosed with CP before they get diagnosed with Krabbe. So, toe walking, even if it's in a later kid. So for this individual with this data, in the absence of knowing the brother, I would, discuss with the family about, what I think the diagnosis is, but would want additional phenotyping before referring to transplant, and would want to do that definitely within a month, probably within a couple of weeks. I personally would do it as a coordinated pre-scheduled admission, get everything lined up, have her come in, get all the tests within like 2 days. And all the tests, MRI, lumbar, in this case, I think a lumbar puncture would be potentially helpful, and nerve conduction.
Yeah, so I agree with that. I think that we'd want to be getting to the bottom of this pretty quickly to make sure that we're not missing any kind of time window, although given that parents hadn't noticed, we're not sure about their observation skills or whatever, but presumably it was a slow progression.
I don't want to misrepresent. The grandparents noticed first on a Christmas trip, but then the parents started noticing things. And in retrospect, she's a first grader. And in retrospect, they had noticed she was tripping more and falling more. It just didn't all come together until they had that visit with the grandparents.
Gotcha. And we'll come back to this fourth question, but let's move forward.
And I do want to add, I would not obviously agree with the diagnosis of CP, but if someone comes into PCP's office and says my child, 6-year-old, is toe walking, that's the first and possibly the only thing that would be in the differential, but would get hopefully referred.
When we're talking about, and just to kind of back up a step, when we're talking about a 6-year-old with tremor, ataxia, and toe walking, Krabbe disease would not be the top of my differential, and I would not send genetic testing or whole enzyme testing first. I would get, whole exome sequencing. I would get enzyme testing first, which is so fast and will help narrow the differential, and get an MRI first. Because when we're talking about doing a fast workup, a whole exome is not the fast workup. So enzyme testing, we talk so much about genetic testing, but enzyme testing would have also gotten quicker to the targeted gene testing, because obviously MLD is high on the differential too.
Yeah, absolutely. I think that this played out a little differently than it would usually.
And I'm just stating like
Yeah,
the
no, it's a
obvious
great
when we
point.
talk about workup and how fast it is to work
Yeah.
this up. It sort of went about kind of a serendipitous route.
Yeah, yeah, absolutely. Because I agree, if I had seen this patient in the office and this was certainly any of these symptoms at also progressing in any kind of way, obviously we'd want to get an MRI scan as part of an initial workup. It's interesting because enzyme testing and rapid genome is kind of similar in how long it takes to come back, I think, but both are really important. Well, that's true. Yep, I agree.
So I think that different centers are different. So
Yeah.
I'm cautious about making blanket recommendations for rapid
Yeah.
genome, because I think that's not standard in a lot of places. And and we've had patients where we've sent quote unquote leukodystrophy panels and we've missed things that we would have found on enzyme testing. So I still want to put a plug in for enzyme testing.
Yeah, I 100% agree because we've actually had that same situation. So the enzyme testing is really important. So moving on to the
But
slide here.
remember, this was Denmark. So it's a
I am not, I am not criticizing the evaluation of this case. I'm stepping back for a broader audience and explaining that a sequential workup when we initially see, it's much more common for us, when we initially see these kids, for sure.
Yeah.
I get it.
I think it's a great point, but I think the world is changing. So this kid, when they called us, they already had the genetic result, right? And that's happening more and more. And then you have to, I don't call it go backwards, but you have to sort out, what does it mean? I've had a few cases, not Krabbe, but other diseases where people thought the genetics was it, you're done. And
Correct,
don't
yeah.
agree with that.
And my point is that once we're getting this, we're considering it an emergency. But my point is that it was an emergency from the beginning. And I worry that the message of sending genetic testing is taking too long if you can't get rapid.
That makes sense. Thank you. So here's some of that additional testing that was done, presumably as quickly as it could be done. You can see, and I'll show you the images in just a moment, that there were some changes consistent with demyelination on the MRI scan with an elevated CSF protein, which we see in Krabbe disease as well. A little bit of slowing on EEG. EEG is more nonspecific, I'd say, in terms of the findings that we might expect on there. And
if I could just say, this kid had EMG or nerve conduction, but she was not cooperative and her parents were very upset about making her uncomfortable. So it wasn't a good test.
so here we can see two axial MRI images. On the left, it looks like a flare sequence, and on the right, it looks like a T2 weighted sequence of two different cuts. And what we're seeing is hyperintensity here in the kind of symmetric hyperintensity in the posterior parietal occipital region, as well as on this cut, symmetric, more significant hyperintensity, I'd say, in terms of signal in the bilateral parietal region. So this, I think, would be concerning for Krabbe disease in terms of demyelinating changes. So what are people's thoughts about transplant? And we know that we hope to transplant patients when pre-symptomatic, but there's data as well in early symptomatic. This girl is extremely functional and doing very well overall. So any particular thoughts on transplant in general, or how we might put this to a family or talk about it with a family? Yeah.
I'm sorry, this is Stephanie from Atlanta. I just had a question. Sorry, I raised my hand before you asked a very good question. But in this case, you already have a genetic diagnosis and you have a child that's symptomatic. I can understand doing the testing, and of course we want to know the MRI and all of these things, but doing the lumbar puncture and getting the protein and the EMG and the EEG, those things, are you doing those more for just your continued follow-up of the patient and additional information? Or is there anything about those tests that are really going to change your mind for transplant when you have a child that you have symptoms and you have a diagnosis of Krabbe?
So I'll take that. I think it's really important to stage the kid that you're considering taking to transplant. And these are kind of the tests we know may or may not be abnormal. And if you go back to our newborn paper, you know, most newborns had some abnormalities in a variety of these tests, but not full abnormalities in all the tests. And so for me, and we are the doctors for this kid, you know, I thought it was really important, A, to document disease activity, not just, even though we had symptoms, and also to know we were going to follow post-transplant. I also think it's important to have this data for future tests of gene therapy or other new modalities that hopefully come before us, so that we have comparators and we can quickly show whether whatever the new intervention is making a difference. And if you don't have baseline studies, then you don't know where you just can't do that kind of work.
Yeah, but does it change, is there anything in those tests that would change your mind about transplant or
Well,
make a determination?
I think, well, taking myself out of my head of this patient where the circumstances were different. I think knowing the MRI is abnormal, these tests, and again, we schedule them in 2 days. So I don't know which ones are going to be abnormal or which ones are going to be normal. And we do the LP under the sedation of the MRI. So we only have one sedation. So, you know, it's easy to look back and say, oh, you only needed this or that, but we don't know which ones, if any, will be positive. For me, having neurophysiologic or imaging results that were also abnormal strengthened the case to say it's time to take this kid to transplant if that's what the family elects to do.
Even in a patient that's symptomatic?
Yeah.
Dr. Ream?
I think we're saying these symptoms are due to Krabbe, and if that is true, we would definitely expect some of those abnormalities. If we did all these tests and they were all normal, I would consider going back to the genetic testing. There are things, you know, there's spinocerebellar ataxias, there are triplicate repeat disorders that may not be adequately covered on the exome. So there are other things that cause toe walking and tremor in somebody this age. And if there's nothing else to point to Krabbe, I would have to ask again, is this Krabbe?
You know, and here, as a transplanter, the conversation I'm having with the family is about risk. And, you know, there's a risk, and it's probably 10% or more, this child will die from the procedure. And is it justified to go forward? And are they, comfortable is the wrong word, but can they accept that decision and quote unquote live with themselves later if the child dies? So I want to be sure. I don't want to have any question marks.
A couple quick questions from the chat that I think I can answer. One was, do you have any information on the cytosine levels in the dried blood spot sample? The newborn screen, the answer is no, because this was not a patient who underwent newborn screen. They're not from the US.
They are from the US. They just weren't born in a state.
They weren't, oh, I didn't know that. Okay, they weren't born in a state with newborn screen. Do you have, and then the second was, would it be possible to test the cytosine in the dried blood spot of these two siblings? And we have the cytosine in the RBCs, which I think is the more reliable specimen, right? So we wouldn't necessarily go back to dried blood spot, particularly if we don't have a previous value. Yes? Okay.
Here, sorry.
Oh, go ahead.
Oh, someone else. I just wanted to, if I were seeing this kid, or one question I had is, yes, there are positive MRI findings, but I want to know what the degree of involvement is and how it pertains to low scoring, for instance, as to, what will tilt the balance towards transplant benefit or not. So we'd love to ask the panel, how do you incorporate any of the evidence on low scoring in kiddos with Krabbe? And how does that influence the child's eligibility to transplantation? And a follow-up question is, in a kiddo who is, how do we interpret that in the context of a kiddo with stable symptoms versus a kiddo who is actually having advancing symptoms in this condition?
So Jim Provenzali, who's the guy at Duke who generally reads the Krabbe films, did publish a scoring system adapting the lowest score for Krabbe in infants, not in later onset cases. And I don't know that we have good data about correlation of the MRI with either function or outcome in older patients. When I take a history on these kids, I always probe with the parents how the kids changed over the last 6 months and over the last 3 months. And if there's, and you know, this happens in ALD even more, I think. If there's a lot of change, rapid change, you know, in the last 3 to 6 months, I'm much less enthusiastic about going forward. And I'm much more pessimistic about predicting functional outcome. But generally in juvenile Krabbe, it's a slow progressing disease and you do have time. And in this case, yeah, the parents did notice a little more gait abnormalities. In fact, they thought she had vision abnormalities, but as it turned out when we tested her, she did not. But it was slow and we felt comfortable recommending to proceed. But it's a call. I mean, at least at this point, there's no AI that I know of that gives you the answer. Hopefully someday we'll have it.
Dr. Bradbury? Last question about this case, and then we're going to move on to the next one.
So I think
And
with
yep.
the changes in MRI, it made this case a little bit more clear. But my question was, because this patient was cognitively normal and most of the deficits were in motor, what if the MRI was normal, but the nerve conduction was abnormal? What would you have just monitored by MRI until you saw some demyelination?
So if I felt I had an accurate nerve conduction study and it was abnormal, I would proceed. But if I couldn't really, nerve conduction can be really hard to interpret, as Margie knows. Anyway, and this kid was not cooperative for her study, which may be a sign her nerve conduction is more normal because it was painful for her. You know, I would wait and repeat in a few months, 3 months, 6 months, something like that.
Yeah, it's just
Yeah.
interesting since we know transplant has,
Yeah.
you know, more of an impact on the central nervous system
Yeah.
than the peripheral nervous
Right.
system. Thanks.
Yeah. But
Oh, all right, I'm going to move forward. It's great. We have a lot of great discussion here.
just go one more.
Oh, well, I was just going to point out that this girl did get transplant, and you can see some of the transplant information there, but I won't repeat. Then she's now 3.5 months post-transplant. And do you want to just tell us a little bit about how she's looking?
Yeah, I mean, she had a pretty, she had got BSA-ATD, which is myeloablative. She got standard GVHD prophylaxis. She had reactivation of HHV6, which, by the way, we always look for in the CSF as well as the blood and find often in these asymptomatic kids, but it helps with transplant management. And she responded to antiviral therapy with that. And she's been discharged and is still in Durham because her brother's also. But here's what she looks like a few weeks ago. So, you know, she doesn't walk completely normally, and she's got spasticity in her thighs, and she does do some toe walking, but not all the time. And she's in PT, but actually doing quite well. Very different from an infantile case.
Okay. Figure out how to move these slides forward. There we go. So we don't have that much time left because we talked a lot about the case. That's great. We have another couple cases after this that we might not get to everything, but I just wanted to share with you the information that we had been talking about. This is the brother of that patient who's a 9-year-old, as we mentioned, has autism spectrum disorder with the exact same genotype. You can see that cytosine in red blood cells was slightly lower than in his sister, but still elevated. And the GAL-C enzyme testing was actually lower than in his sister. So it just speaks to the challenges around using the exact GAL-C enzyme level to predict outcome. In this patient, there was a mildly abnormal EEG with some slowing, but otherwise normal. Other tests, oh, the MRI in here, the MRI was normal. Sorry, I missed that.
Say pathogenic, you're obliged to unpack all the PubMed ID papers that go along with that and tell me what kind of private patients.
Absolutely.
Okay.
Yeah, so Dr.
Because
Gelb is,
pathogenic to me means almost nothing.
yeah, so this is just a summary slide, but
Okay,
what
okay, I
Dr.
just-
Gelb is pointing out a very good point, which is when you get this report back and you're looking at a report that says pathogenic, you need to understand what pathogenic means in this context and need to understand from the literature what types of patients were presented here. What types of patients had the same genotype. So we don't have too much time for discussion questions here, but Dr. Kurtzberg, do you just want to tell us what happened with this boy? And as you're doing that, I'll show up. I don't know if you can see these, but the case 1A is the sister, case 1B is the brother, and you can see the cytosine values and GAL-C values on there.
Dieter wants to comment on.
Dr. Kurtzberg, can I ask a question? Well, so
Yes.
with that difference,
Who's talking?
would you recheck? Would you check, let's say you have a baby that you get tested and you think the newborn screening was negative on a sibling, where it can differ a little, do you still then check the whole family?
I'm sorry, I have trouble hearing and I couldn't hear.
I was saying since it seemed like the brother and the sister were or could they be different enough that one could be missed on newborn screening?
On
So
newborn
if you-
screen, yeah.
So I'm just wondering, because I would think if you have a family where everyone was born in New York, you might think you're okay to not test the other siblings. And I didn't know if it's enough of a discrepancy that you should test anyway.
Well, first of all, I don't know what would have happened on newborn screen for these two siblings. I'm not sure they would have shown up or not. I think probably not, honestly, but I don't know. But if I have a family with a kid with Krabbe, particularly non-infantile, and there are other siblings of whatever age, we test them because I don't think we know. And particularly in these later onset forms, the age of onset can be variable. And with this kid who's 9 and who's got autism, but really I don't think autism is a feature of Krabbe disease. Really all his studies were normal. He had an abnormality in the EEG that was not consistent with epilepsy or pre-epilepsy, and I don't know what it means. The family was so anxious. They literally insisted we move forward. I talked them into sequential instead of simultaneous because one, I wanted them to know what they were getting into with the symptomatic kid where it was clearly justified. And, you know, she did well, which is great, but it biased them against, you know, towards moving forward with the older kid. And they're very, very worried he's going to get symptomatic and they want to prevent that. Their other worry was that we wouldn't, and I quote, take away his autism because they felt his autism was a valued character trait and they didn't want to lose that. You know, I don't think transplant would affect that. And that's what we told them. But anyway, this was a situation with a family with a lot of knowledge that was driving them towards whatever treatment they could find for now, and then hopefully more later.
Rob, I mean, Joe and Dieter can comment, but I think with such low enzyme activity level that they both would have been picked up in New York State, at least on
They
screen.
would say
They would have.
would have.
Yeah.
But there's like
Well, that's a different question, but would they have triggered the screen? I think the answer is yes.
Because in New York State, we get a screen, even with a normal cytosine, if the GAL-C is low. Right, Joe? And the genotype is,
We've been moving away from that unless the activity is really low.
Mhm.
Mostly because of that one particular case where we found very low enzyme activity and two variants that were associated with infantile disease, but cytosine was normal. So that kind of, but if we have like, I call it high, on the high side of low activity, we're going with the cytosine.
Gotcha. That's great. So I just wanted to point out one thing here, and then we're basically out of time. We're talking about the cytosine being on the lowish side, but you can see here that for the girl, the first patient we talked about, the cytosine and RBC values right at the mean for juvenile Krabbe disease. So that 10 is a value that seems, at least in the small number of patients that we have the data on, seems to be a reasonable value to consider that diagnosis. We're out of time. Thank you so much for our great panelists and for everybody for that excellent discussion of our sibling pair here.